Hello, students. I am Dr. Saira Mehnaz. I am a professor of community medicine at Jawaharlal Nehru Medical College, Aligarh Muslim University, and I am here to give you a course on reproductive and child health, often referred to as RCH. This opening session serves as an orientation, giving you a clear picture of the course structure, objectives, teaching methods, and expected outcomes. Over the coming weeks, we will explore the sociological, medical, policy, ethical, and advocacy dimensions of RCH. The course has been carefully designed to progress logically from foundational concepts to advanced applications, ensuring that you not only acquire knowledge but also develop critical thinking, advocacy, and professional skills relevant to the field of public health, sociology, and social work. Now, reproductive and child health lies at the heart of public health, representing both a moral and developmental imperative. Maternal and child mortality remain among the most critical indicators of a nation's health system and its social equity. Adolescents, too, form a vital demographic whose physical, emotional, and reproductive health needs shape the well being of the future generations. Studying RCH allows us to address pressing issues such as family planning, nutrition, immunization, gender inequality, and child protection in an integrated manner. More than a biomedical field, RCH is fundamentally about rights, equity, and justice, ensuring that vulnerable populations are protected and empowered to make informed choices. It highlights the interdependence of social, cultural, and economic factors in shaping health outcomes and policies. By understanding RCH, we learn how public health interventions can transform not just individual lives but entire communities. Ultimately, RCH embodies the vision of inclusive, compassionate, and sustainable health systems, where every woman, child, and adolescent has the opportunity to survive, thrive, and contribute to the society. We are going to study RCH for a period of 12 weeks through 8 modules and 60 lectures. The first 3 modules will provide the foundation. Module 1 introduces the field, its scope, and indicators. Module 2 takes a sociological lens examining how family, culture, migration, and gender roles shape reproductive health. Module 3 transitions into public health policies and programs, offering a deep dive into maternal and child health services, family planning, adolescent health, and program evaluation. These modules give you context and grounding before we move into more complex issues. The middle section of the course focuses on gender, clinical health, and community interventions. Module 4 emphasizes gender, sexuality, and reproductive rights, including legal and ethical dimensions. Module 5 is devoted entirely to children, covering growth milestones, illnesses, nutrition, disability, protection, and education. Module 6 highlights the role of community and social work, exploring mobilization, counseling, NGO roles, and innovative service delivery. Together, these modules integrate health with rights and social justice. The final 2 modules bring the course to a higher level of application. Module 7 builds your research skills, covering methodology, data collection, analysis, program evaluation, and ethics in RCH research. Module 8 brings together ethical issues and advocacy, exploring dilemmas, consent and confidentiality, global perspectives, and future trends. By the end, you will have a comprehensive understanding of both practical and ethical aspects of RCH. The expected outcomes of this course are multifaceted and designed to shape into a well rounded professional in your respective fields. You will gain a solid understanding of key RCH concepts and indicators, learning to interpret them in both national and global contexts. You will also explore how socio-cultural contexts such as gender roles, family systems, and community norms influence reproductive and child health outcomes. Through this understanding, you will be able to critically evaluate existing policies and programs, identifying their strengths, limitations, and opportunities for improvement. Moreover, you will develop essential research and advocacy skills, practical competencies that empower you to translate evidence into action and policy. The course will help you appreciate the interconnections between public health, social work, and community participation in achieving sustainable outcomes. By the end, you will be able to apply theoretical frameworks to real world problems and contribute to strengthening the RCH systems. Ultimately, these outcomes aim to prepare you as reflective practitioners, professionals who combine compassion, evidence, and equity to improve the health of women, children, and communities. There is a definite integration across all modules, linking theory and practice, building perspectives from individuals to the system, so as to assure the continuity of learning. A strong focus of this course will be the Indian context, as India's journey in reproductive and child health provides a rich and complex case study. We will trace the historical evolution of RCH programs, from early family planning initiatives to integrated frameworks like RMNCH plus A and the National Health Mission. Through this, we will assess both the success and persistent challenges, such as regional disparities, programmatic gaps, and implementation barriers that shape India's public health outcomes. We will also situate these experiences within broader global health discourses, connecting India's policies to international goals like SDGs and WHO's Universal Health Coverage Agenda. India's vast population diversity, socio-economic inequalities, and multi-tiered health system make it to a living laboratory for learning about what works and what needs innovation. The course will help you appreciate how RCH policy in India balances scientific evidence, cultural realities, and political priorities. It will also emphasize the role of community participation and intersectoral collaboration, which remain critical for achieving sustainable health gains. Ultimately, understanding India's RCH landscape will allow you to apply these insights comparatively, identifying lessons for both developing and developed health systems worldwide. At the same time, we will continually link the Indian experience to global trends. Shared challenges such as maternal mortality, adolescent health, and gender inequality are present across countries. We will also discuss global advocacy movements such as SDGs and Every Woman, Every Child, providing comparative perspectives that enrich understanding. Ethics is woven throughout this course. We will examine the principles of informed consent, confidentiality, respect for rights, and justice in health delivery. This ethical lens ensures that discussions about policies, services, and research always prioritize human dignity and fairness, particularly for marginalized and vulnerable populations. Advocacy will also be a core theme. You will learn how to advocate for reproductive and child health rights, influence policies, and mobilize communities. Advocacy skills complement technical knowledge, enabling you to act as agents of change who can bridge gaps between communities and policymakers. Research forms another important dimension. We will emphasize evidence based practice, explaining how research informs programs and policies. You will learn about specific research methods for RCH, data collection, and analysis. By linking research to policy, we will highlight how knowledge can be translated into real impact. The community perspective is central to this course. We will highlight the voices of women, children, and adolescents and examine how cultural practices shape health behaviors. Empowering communities to take ownership of their health is a guiding principle. This ensures that RCH is not reduced to statistics but understood in terms of lived experiences. Empowering communities by participatory learning with women's group, village health and sanitation committees, and school based peer leaders, so priorities come from the ground up. Social norms include engaging fathers, mother in laws, and religious community leaders to shift beliefs around early ANC, colostrum, spacing, adolescent nutrition, etc. Community scorecards and simple dashboards let villagers rate village health nutrition day quality, ambulance responses, and Janari Suraksha Yojana entitlements, creating visible accountability. Story circles and social autopsies after adverse event will convert pain into practical, time bound changes that the community tracks. Inclusion by mapping hard to reach hamlets and migrants, single mothers, persons with disability, and marginalized castes. Frontline voices like Ashas, Anganwadi workers, ANMs will be treated as co designers, not just implementers, and their feedback directly shapes microplans. Finally, we talk about dignity and trust, respectful maternity care, informed consent, and zero expense access. Because when communities feel respected, service uptakes and health outcomes follow. RCH is inherently interdisciplinary, bringing together medicine, public health, sociology, social work, law, ethics, and policy studies. The interdisciplinary makes the field rich but also complex. Through this course, you will see how these different disciplines interact and complement each other in addressing reproductive and child health. The impact of this course it goes beyond academics. It aims to build professional competence in health and social sectors, preparing you as advocates and researchers. Ultimately, the knowledge and skills gained here should contribute to stronger RCH systems, whether through policy influence, service delivery, or community engagement. The course has direct relevance to careers. Public health professionals can apply this knowledge in program design and evaluation. Social workers and advocates can use it in right based approaches. Researchers and educators can build on it to produce knowledge and train future professionals. RCH is a versatile and applied field that opens multiple career paths. We expect students to dedicate time and effort, actively participate, and engage with an open mind. Ethical sensitivity is very crucial. These topics are deeply personal and socially sensitive, requiring respectful and thoughtful discussions. Your active role will enrich the collective learning experience. RCH is not just a health issue, it is central to national development. Healthy mothers and children are the foundation of economic growth and social stability. RCH is directly linked to the Sustainable Development Goals, particularly SDG 3, which relates to health, and SDG 5 to gender equality, and also accelerates SDG 1, which says no poverty, SDG 2 related to nutrition, SDG 4 related to education, and SDG 10, which talks about reduced inequalities by breaking intergenerational cycles of disadvantage. Investing in antenatal care, safe delivery, newborn care, immunization, and family planning yields one of the highest returns in public finance by preventing productivity loss from stunting, anemia, and early mortality. In the Indian context, programs like GSY, Lakshya, Poshan, and HBNC translate right into routines, reducing catastrophic expenditure, keeping girls in school, and enabling women's participation as an active workforce. Strong RCH systems also build resilience for shocks, pandemics, climatic events, displacements, because they anchor supply chains, community trust, and last mile referral networks. Studying RCH, therefore, equips future physicians, public health leaders, and administrators to govern with a human capital lens, where every safe birth, every vaccinated child, and every informed reproductive choice is treated as nation building. Ultimately, RCH is a justice agenda. When the poorest women in the remotest hamlet receives timely, respectful care without out-of-pocket burden. So we come towards the process of health equity. So there is I'm going to talk about a simple case study where we are going to see how these health programs of the government are implemented and the total health status of that rural block in our example comes up. So there is a typical rural block with 1 CHC, 4 PHCs, and 36 subcenters. We use this as an imaginary example to show how the RCH, RMNCH plus A approach can reliably move outcomes. In 2016, women often booked ANC late. Many deliveries occurred at home, supplies were inconsistent, and referrals failed at night. The baseline data showed institutional delivery was only 62% and 38% women completed 4 ANC visits, while only 61% children were fully immunized and an infant mortality rate was around 42 per thousand live births. This case is about process discipline across the continuum, from pre pregnancy to the newborn period, rather than expensive new infrastructure. Here, two binding constraints shape our plan: dependable night transport and consistent commodities. Demand side barriers like low risk perception and delayed ANC also mattered. As we proceed, watch how fixed days, visible entitlements, and a quality improvement culture combine to turn the curve in this tough setting. Maybe at this point of time you don't understand some terms and phrases and they appear very tough. But throughout the course, keep this case study in mind, and maybe you are able to relate this study every time we go to a new module. Thank you. So, change came in this block. Change came not from a single intervention, but from five reinforcing pillars that work together to transform maternal and child health outcomes. Community platforms created name duo lists and institutional village health and nutrition days, where women's group challenged myths, promoted behavioral change, and strengthened social support systems. Service readiness was enhanced through initiatives like Lakshya for quality improvement in labor rooms, skilled birth attendants, and Navjat Shishu Suraksha Karyakram trainings, and integrated management of neonatal and childhood illnesses. While the Pradhan Mantri Surakshit Matritva Abhiyan provided fixed day specialist antenatal care for early high risk detection. Entitlement insurance made schemes such as Janani Suraksha Yojana and Janani Shishu Suraksha Karyakram more visible and credible. Convergence with the ICDS brought growth monitoring, nutritional counseling under Poshan Abhiyan, and linkages with nutrition rehabilitation centers into synchronized community action. Then we had data driven monitoring, which became the fifth pillar of systems like e vaccine intelligence networks and maternal and perinatal death surveillance and responses. and referral tracking of the first referral units. These results reflect the significant progress achieved under the strengthened RCH framework and the National Health Mission. We did not introduce any new infrastructure or program, just implemented the already existing programs in the right manner and in the right spirit. Institutional delivery coverage rose impressively from 62 to 88%, demonstrating increased trust in public health. Facilities and effective financial and community mobilization through ASHAs and schemes like JSY. Antenatal care indicators improved notably, with 4 or more ANC visits increasing from 38 to 74%, and early ANC registration rising from 32 to 69%, highlighting better outreach and early risk identification. In child health, full immunization coverage expanded from 61 to 86%, while early initiation of breastfeeding jumped from 45% to 78%, reflecting integrated newborn care and behavior change communication. Quality parameters improved too, with pantograph use exceeding 85% and first referral unit access within 90 minutes improving from 54 to 81%, ensuring timely obstetric and neonatal care. Risk outcomes also showed a positive trend. Low birth weight declined from 19 to 12%. Postnatal care within 48 hours increased from 41 to 76%. And the infant mortality rate dropped from 42 to 28 per thousand live births. Very importantly, the equity gaps were narrowed, with institutional delivery disparities between remote hamlets and main village shrinking from 24% to just 9%, providing that inclusive, data driven, and community centered approaches deliver results. The mechanism explains the results. Fixed day village health and nutrition days and granular microplans let families and provider plan reliably. Shrinking missed contacts. Entitlement assurance, prominent JSSK rights, and quick grievance redress reduced hidden costs and restored confidence in facility delivery. On site skills with simple checklists make labor and immediate newborn care consistently safer without heavy capital spend. Convergence with ICDS ensured nutrition counseling and early identification of growth faltering. This became routine rather than optional. And referral readiness focused on logistics, phone trees, driver rosters, alignment with 108, 102 ambulances, and simple escalation. Standard operating procedures saved precious minutes of emergencies. Transparent reviews and small village health, sanitation, and nutrition committee investments solved hyperlocal bottlenecks that often decide whether services are actually used or not. What are our reflections now? This is my closing reflection for this lecture. Caring for mothers, newborns, and children is the surest way to secure a nation's tomorrow. In this course, you will be pushed to reason carefully and act with moral clarity so that no family is sidelined by development, keeping rights at the core. Dignified childbirth, informed contraceptive choices, and cash free access under public entitlements must be standard practice, not perks. Think across levels. What you observe in a hamlet should inform block reviews, shape state decisions, and align with global targets. Then circle back to practical steps in the village. Pair compassion with proof. Listen to community narratives while tracking the simple metrics that show whether care is timely and complete, and use each adverse event to trigger a concrete fix. When trade off arise, limited beds, delayed transport, social gatekeeping, choose actions that protect dignity and narrow inequalities. Real leadership is weekly visible reliability. A working ambulance roster, entitlements actually delivered, and a closed feedback loop after every incident. Carry this habit beyond the classroom. As clinicians and managers, your credibility rests on routines that people can rely on. If we keep the process honest and the community in a driver's seat, we will see safer births, healthier childhoods, and a fairer public health system. To summarize, the course is structured into 8 modules and 60 lectures, progressing from introductory concepts to complex ethical and advocacy themes. It integrates theory, practice, ethics, and advocacy, preparing you for professional roles in health, social work, policy, and research. This course is designed to be transformative, equipping you with the skills to make a real impact. Thank you for your attention. This concludes the introductory lecture. In the next session, we will move on into the historical evolution of reproductive and child health programs in India, tracing the journey from early family planning initiatives to the integrated RCH approach. This history will provide context for understanding present day programs and challenges. Thank you.